In this video, I go over spinal nerves and the general structure of neurons. We're going to describe the anatomy of the nerves and ganglia. We're going to describe the attachments of spinal nerves to the spinal cords. We're going to trace the branches of the spinal nerve distal to its attachment. We're going to name the 5 plexuses of the spinal nerves and describe their general anatomy. We're also going to name some major nerves that arise from each plexus. We're going to explain the relationship of dermatomes to the spinal nerves. So first we need to talk about the cell body. So this is the cell body here of a neuron. It's the control center of the neuron. It's also called the neurosoma. It has a single centrally located nucleus right here. You can see that. There's the nucleus with a large nucleolus. So you can see the nucleolus in there as well. It has cytoplasm, which contains mitochondria, lysosomes, Golgi complex, inclusions, extensive rough endoplasmic reticulums, and cytoskeleton. Notice it does not have centrioles, and therefore it's not going to go through mitosis. Therefore, nerve tissue is very hard to heal. So we also have these things called dendrites. So right here. These are branches that come off of the cell body or the neurosoma. It's a primary site for receiving signals from other neurons. So these dendrites up here, they're going to receive signals from other neurons. The more dendrites the neuron has, the more information it can receive. It can provide precise pathways for the reception and processing of information. An axon of a nerve right here, this is an axon. Which is also known as nerve fiber, originates from a mound on the neurosoma called the axon hillock right here. So this is the axon hillock here. The axon is cylindrical. It's relatively unbranched for most of its length, which axon collaterals are branches of the axon. So here we can see that we have some axon. We have an axon collateral right here, so it's a branch off the axon. It does branch extensively on the distal end here, so right here. And it's specialized for rapid conduction of nerve signals to distant points. Axoplasm is known as the cytoplasm of the axon here. Axolemma is the plasma membrane of the axon. Only one axon per neuron. So you only have one axon per neuron. Some neurons have none. So myelin sheath may enclose the axon. So these little bubbles here, these are the myelin sheath right there. So that distal part of the axon has terminal arborization, which means extensive complex branching. So here's the distal axon here. We have lots of branches here, terminal arborization there. The axon terminal has a little swelling that forms the junction known as a synapse. It's going to synapse with the next cell that it's going to contact with. It contains synaptic vesicles full of the neurotransmitters. So axon terminals, you can look right there, the little swellings right there. And we've already gone over this when we went over the neuromuscular junction. We went over the axon terminal. So now we need to go over the structural classification of neurons. So multipolar neurons have one axon and multiple dendrites. So here's a multipolar neuron here. So there's one axon, multiple dendrites. Bipolar neuron has one axon and one dendrite. So bipolar neuron here has one axon and one dendrite. And it has olfactory cells. These are common in olfactory cells, the retina and the inner ear. So special sense cells here. Unipolar neurons have single processes leading away from the neurosoma. These are sensory cells from the skin and organs to the spinal cord. So unipolar neuron here. So it has that single process. An anaxonic neuron has many dendrites but no axon. So right here, These are found in the retina, the brain, and the adrenal glands. So now let's go over some more anatomy. So the spinal cord communicates with the rest of the body by way of the spinal nerves. So here you can look at a spinal nerve coming off here. Nerve is a cord-like organ composed of numerous nerve fibers, which those nerve fibers, those are the axons, bound together by connective tissue. Mixed nerves contain both afferent, that sensory information, and efferent, that motor information. So again, we went over cranial nerves, and some are mixed and some are only motor, some are only sensory, so that makes sense. So nerve fibers of the peripheral nervous system are surrounded by Schwann cells forming neurolemma and myelin sheath around that axon. So the endoneurium, let's go over the connective tissue layers. So the endoneurium is a loose connective tissue external to the neurolemma. So the neurolemma is that plasma membrane of the nerve cell, neurolemma. So if we look at the picture here, so this is your endoneurium right there. The perineurium is the layers of overlapping squamous cells that wrap fascicles, bundles of nerve fibers. So perineurium, we're going out here. So this is your perineurium here. And then surrounding the entire nerve is actually the epineurium. So again, same pattern, epi-peri-endo. Epi-peri-endo, just like with muscle tissue, we have the same pattern. Instead of endomysium, you have endoneurium. So it's the same pattern. So epineurium, it's around that entire nerve, so right around this whole nerve. We also have blood vessels that are going to penetrate connective tissue coverings and that provide plentiful blood supply. So as we said, sensory nerves are known as afferent nerves. They're going to carry signals from the sensory receptors to the central nervous system. So I always remember sensory nerves are afferent nerves because afferent, you have an A, and if you have a capital A, it looks like an arrow pointing up, and you're going to bring information up to the brain into the central nervous system. So afferent nerves must be that sensory information, must be carrying that sensory information, and then motor nerves would just be the opposite. So motor nerves are known as efferent nerves. They're going to carry signals from the central nervous system to muscles and glands. We have mixed nerves, which consist of both afferent and efferent fibers, so both that sensory and motor fibers, both of those. And we talked about this with cranial nerves having mixed cranial nerves and only motor cranial nerves and only sensory motor nerves. So both sensory and motor fibers can also be described as somatic or visceral, or we can call them general or specific or special. On that last slide, I talked about somatic and visceral. I didn't talk about it, I just listed it. So somatic and visceral. So visceral is going to be going to internal organs, and somatic would be going to the skin, the muscles, the connective tissue, something like that. That's important when you talk about if you're describing, if you want to label the patient somatic pain versus visceral, you want to say patient's having somatic pain or visceral pain. So visceral coming from those internal organs, somatic pain coming from the muscles or the skin, or those connective tissue. So now let's talk about the ganglion. So the ganglion is a cluster of cell bodies, also known as neurosomas, outside of the central nervous system. So it's going to be enveloped in an endoneurium continuous with that of the nerve. So we can see this. So here is a ganglion right here. This is your posterior root ganglion. Here's your anterior root ganglion here. Among cell bodies are bundles of nerve fibers leading into and out of the ganglion. So we have a ton of these cell bodies here. We can see all these neurons, these cell bodies here, and then we also have a lot of nerve fibers coming into and out. So it's important to know that the posterior root ganglion it's going to be associated with spinal nerves. So you're going to have sensory information coming in the back. So here's a spinal nerve here. So this is a spinal nerve here. We're here and here. So sensory information is going to come in through that posterior root ganglion. So if this is sensory, if my clicker here is sensory information, it's coming in here. It's going to go through that posterior root ganglion. So sensory information is going to come in the back door, and motor information is going to come out the front here. So this would be anterior here, this would be posterior. So sensory information goes in the back door, and motor information is actually going to come out the front here. So this is the anterior root here, and this is the posterior root. So motor information, it's going to come from the central nervous system, and it's going to come here, right there. So again, here is the spinal nerve. So these are both backwards, so it can kind of make it confusing here. So posterior root ganglion here. So sensory information coming in the back, and motor information coming out the front. We can see that right there. So now let's talk about your spinal nerves. So you have 31 pairs of spinal nerves. These are mixed nerves. So you have 8 cervical spinal nerves, C1 through C8. And how many cervical vertebrae do you have? So you have 7 cervical vertebrae, but you actually have 8 cervical nerves. So the first cervical nerve exits between the skull and atlas. So we're starting up on top. That first cervical nerve is actually going to be coming above C1. So it's going to come out above C1. Others exit at the intervertebral foramina. You have 12 thoracic nerves, you have 5 lumbar nerves, spinal nerves, and you have 5 sacral, and you have 1 coccygeal nerve. So this is important to figuring out which nerve is being affected in certain pain situations. Also in paralysis, if you're having trouble with different nerves, you can test and figure out what nerve is actually the problem, and we're going to go over that a little bit later when we talk about dermatomes. So as we saw in that picture that we had, not the last one but the one before, so each spinal nerve is formed from 2 roots, the proximal branches. So you have your posterior dorsal root, which is, remember, posterior sensory information comes in the back and motor information comes out the front door. So posterior root is sensory input to the spinal cord. The posterior or dorsal root ganglion contains the neurosomas, those cell bodies of sensory neurons carrying signals to the spinal cord, and 6 to 8 rootlets enter the posterior horn of the cord. So we had that in that picture too. I don't have that picture up right here now, but we'll be able to see that in a little bit. The anterior ventral root is motor output of the spinal cord. 6 to 8 rootlets leave the spinal cord and converge to form the anterior root. Cauda equina is formed from the roots arising from L2 to C coccygeal nerve number 1. So this is your cauda equina would be from your L2, so we go up to L2 right there, and then to coccygeal, that's the cauda equina. So cauda equina means the horse's tail. So right here, where it looks like this, this is referred to as the cauda equina. So beyond the vertebra, the nerve divides into distal branches. So you have your anterior rami, and let's take a look. So your anterior rami is right here. Your anterior ramus is going to come to the anterior, and then you have your posterior ramus coming back, so going posterior. The anterior ramus in the thoracic region, it's going to give rise to the intercostal nerve. In other regions, the anterior rami will form a plexus. We're going to talk about those plexus in a little bit. So the posterior ramus innervates the muscles and joints in the region of the spine and the skin on the back. The meningeal branch re-enters the vertebral canal and innervates the meninges, the vertebrae, and the spinal ligaments. So here we can see in a different image here. So here's the posterior ramus. We have the anterior ramus here, and then we were talking about the meningeal branch right here. And yeah, you can just see a different view here. So here we can see on a cadaver, we can see that posterior root ganglion right there. And we can also see that anterior root right there. So we're looking for the posterior. Here's the posterior root ganglion. You can see those rootlets here coming together here. So those anterior rami, the reason why we went over those, why those are important, they're going to branch and then they're going to come together repeatedly to form 5 nerve plexuses. So the first nerve plexus we're going to talk about is the cervical plexus, which is in the neck. It consists of C1 to C5, so C1, C2, C3, C4, and C5, and it's going to supply the neck and the phrenic nerve to the diaphragm. We also have, so the cervical plexus is right here, C1 to C5. And then the brachial plexus, which is going to be C5 to T1. So the brachial plexus is near the shoulder. It's going to be C5 to T1, so right here, so C5 to T1. And it's going to supply the upper limb and some of the shoulder and neck. It's going to contain the median nerve, which is important because of carpal tunnel syndrome. That's a problem with that median nerve. Then we're going to have the lumbar plexus, which is in the lower back. It's going to be L1 to L4. So L1 will go down here, and it's going to be right here. So L1 to L4, right there. That is your lumbar plexus. Then we have the sacral plexus in the pelvis, which is going to consist of L4, L5, S1, and S4. So it's going to supply the remainder of the lower trunk and lower limb. Again, that is your sacral plexus. You can see it right here. And then we'll have the coccygeal plexus, which is S4, S5, and coccygeal nerve number 1. So S meaning sacral nerve number 4, and sacral nerve number 5, and then CO stands for coccygeal nerve 1. And you can see that down here. So coccygeal plexus right here, sacral plexus right here. So these nerve plexuses are going to have somatosensory function. They're going to carry sensory signals from bones, joints, muscles, and skin. We're going to receive proprioception. The brain receives information about the body, position, and movements from nerve endings in muscles, tendons, and joints. The motor function, they're going to have motor function as well. So they're going to send out motor function primarily to stimulate muscle contraction for these nerve plexuses. So this is the cervical plexus here again. So C1 through C5. So these are the spinal nerves coming out of the spine here. And you're going to look at some interesting nerves here. So the hypoglossal nerve actually comes down here. And also, let's take a look. So we have the phrenic nerve. That's another important one here. So now let's take a look at the brachial plexus. So we have C5 through T1, C5 through T1. This is a very important plexus, probably one of the most important ones that we're going to go over. Just making sure you know what the different nerves do. A lot of colleges have you actually draw it out and know which spinal nerve comes from each, which roots it comes from. We just really want you to know the nerves. So the axillary nerve is going to come from the brachial plexus. It's very important to know that. The axillary nerve right there. The musculocutaneous nerve right here, coming around here. That also comes from the brachial plexus. Musculocutaneous nerve is going to innervate those flexors, those big muscles of the arm right here, such as your biceps and your brachialis muscle. So flexing your arm. The median nerve, right, coming down the middle, the median, and you have your radial nerve here. So your radial nerve's gonna innervate those extensors of the arm, right? So the triceps is gonna be. So if you're extending that arm, that's gonna be at the elbow, that's going to be coming from your radial nerve. Your radial nerve is going to control that. If there was a problem, if you were unable to maybe flex that arm at the elbow, we would look at the musculocutaneous nerve. We could trace that back. We could go here. So musculocutaneous nerve comes back here. And I already talked about this in one of the other PowerPoints, but we could trace it back to the nerve roots, and we could check out the spine. We could take an x-ray of the spine and see if there's any bone formation that's cutting off those nerves, putting pressure on there, or maybe a disc herniation, which is also putting pressure on there. So it's very interesting. I mean, it's neat. You can investigate what's going on. But yeah, very important plexus, the brachial plexus. Now here we have the lumbar plexus. So you can take a look here, L1, L2, L3, L4, and L5. So L1 through L5. And we have some important nerves coming off here. We have the femoral nerve, we have the obturator nerve, we have the inguinal nerve, ilioinguinal nerve. So make sure you understand that and are able to trace the nerves back to which plexus they actually come from. So here we have the sacral and coccygeal plexuses. So we can see which nerves come from them. So we have that sciatic nerve here. We have the pudendal nerve. We have inferior gluteal, superior gluteal, a few different nerves there that arise from these plexus. So now let's talk about dermatome. So dermatome is a specific area of the skin that conveys sensory input to a spinal nerve. So we create these things called dermatome maps, which is a diagram of the cutaneous regions innervated by each spinal nerve. And I'm going to have a picture up here soon. So the dermatomes overlap their edges as much as 50%. So it's a good test, but if they're overlapping, you really have to double check with motor tests and other tests to make sure that you are locating the problem. So necessary to anesthetize 3 successive spinal nerves to produce a total loss of sensation in 1 dermatome. So they're not 100% reliable, but they are helpful. So here's a dermatome map. So if you take a look here, you can see, so if someone were to, if you took a nail or something, or a pin, if somebody took a pin and let's say they hit this area on your shin here, and they poke that area and you couldn't feel that, then we would look at your L5 nerve, where that comes out of the spine up here, and see if there's something going on there. People who have disc herniations, let's say in different areas of the spine, and if those disc herniations are going on to specific nerves, let's say it's going on to the L4 nerve, somebody with a disc herniation might have numbness, tingling in this area right here in this L4 dermatome. Let's say it was affecting that L5 nerve, the disc herniation was, then the patient would have numbness, tingling in this area. We also have myotomes too. So the different spinal nerves control different muscles. So we can test those different muscles and see if they're showing up. If they have weakness, then there could be a possible problem with those spinal nerves. But here you can look up in the cervical area. Here we can look at C5, or C6 on the outside of the arm. So if somebody took a pin and stuck you with a pin on this side of the body in the C6 dermatome and you couldn't feel it, that would be a problem. And some people do have problems. You can have disc herniations up in the neck, and you can have osteophyte formations, like bone formations, degeneration that can put pressure on these nerves that can make them have numbness, tingling, pain in these areas. Same with the disc herniations causing pain in these certain dermatomes. So as a clinician, you're going to be solving these problems. You're going to be checking these dermatomes. You're going to, especially if you're working in orthopedics. But if you're in primary care, there's going to be a ton of patients with pain, and you're going to be checking these different dermatomes to figure out what nerves are associated, and then you can use further imaging. You can use an X-ray to look at the spine, look at the bones, and then if things aren't progressing, going as well, then you can resort to an MRI and look at those discs, those intervertebral discs, to see if there's a herniation and you can see that soft tissue. On X-rays, you can only see you can't see much soft tissue. It's all basically the bones. But when you get an MRI, you can see that nerve. You can see the disc herniation. You can see that osteophyte. Well, you can see that in X-ray too, but you can see the bone formations, the degeneration, things like that. So many tools in your toolbox, but this will be one of your tools. Also, testing out the muscles, and a lot of course, the patient history. The patient's going to tell you a lot of things that are going on, and the patient history is very important. Of course, your exam as well. You can check all these dermatomes. You can check many different things to figure this out.